All right. Hi, everyone. I think we can get started.
Welcome, everyone. My name is Jade Nair.
And I'm Katie Spoon, and we're excited to share our work enhancing health data about patients and providers at the US Census Bureau. This summer, we've been hosted by the Enhancing Health Data, or eHealth program, which is a research program at Census focused on enhancing health data by strategically reusing administrative records and survey data. The team does this by conducting original research and collaborating with external partners, which is Jade and I through Coding It Forward, in order to improve our understanding of patients, providers, and population health by producing innovative statistical estimates and data products for researchers and policymakers.
Summer, we worked on two separate projects, one focusing on patients and the other on providers. I worked on the patient side, where I developed a data infrastructure to enhance our understanding of long-term care. Long-term care encompasses a variety of continuing care for the aging population and for people with disabilities, including nursing facilities, assisted living facilities, and more. As America's aging population increases rapidly, so does the need for this care. The COVID-19 pandemic caused a significant number of deaths in long-term care facilities amidst a struggle with crisis response, leading to federal initiatives to improve the quality of this care. To inform these developing initiatives, high-quality data is crucial. But existing data sets on this population can lack standardization across agencies or research groups. At the same time, Medicaid is becoming an important factor to analyze, as it's the biggest payer for long-term care, and each state sets much of its own Medicaid policy. This means access to quality care can depend on differing state Medicaid infrastructure. While the census doesn't formally produce statistics about long-term care, we can learn about patients of nursing facilities through their housing classification. Most information at the census is collected through individual households like houses or apartments, which are known as housing units. But not everyone lives in a housing unit, so the census also collects information about organizationally managed housing, or group quarters. This includes nursing facilities and things like jails or college dorms, but the current classification excludes other types of long-term care, like assisted living. This means focusing on group quarters can tell us a lot about nursing facilities, but not about other long-term care facilities that don't provide nursing care. Given the unique data landscape and challenges, I aim to bridge some of the gaps and identify the value add of certain data linkages to our knowledge of long-term care. To gain background, I completed several preliminary items, including informational interviews, policy analysis, and dataset evaluation. But for today, I'm focusing mostly on the data infrastructure, which primarily looked at Medicaid linkage, but also assessed economic linkage. My first linkage was about Medicaid beneficiaries in group quarter nursing facilities. We can identify residents of nursing facilities in decennial data by filtering on what's called their group quarter code, which gives us the dataset on the right. We also have Medicaid enrollment data from the Centers for Medicare and Medicaid Services on the left. Intersecting the two gives us a set of all Medicaid beneficiaries living in nursing facilities. From this group, we can analyze both data quality and demographic breakdowns. By measuring data quality across states, I honed in on areas where missing or duplicate data could impact the utility of research. For demographics, I analyzed the relative densities of the nursing home and Medicaid populations by state, as well as racial and demographic differences from the overall 65+ population. These state-based insights into the Medicaid nursing population can also help analyze the effects of state Medicaid policies. To display these regional differences, I made maps like the one on screen, but as we can't disclose real estimates yet, the visualizations on screen are fictitious. So far, I've just talked about nursing homes, but due to the way group quarters are classified, we can't use these methods to learn about non-nursing facilities like assisted living facilities. To get this broader subset for analysis, I experimented with linkage with business data. The Business Register enumerates all America's businesses by the types of products and services they provide, through an industry classification system known as NAICS codes. By selecting the businesses with NAICS codes corresponding to long-term care, we can get a list of their addresses. We then match the addresses to residents in the decennial census to pick up everyone living at a long-term care business. In the future, this infrastructure can be further optimized and built on to perform in-depth analysis on the broader long-term care population.
So on the other side of the spectrum, I have been exploring a comprehensive new data frame of all physicians in the US and producing insights that could inform access to care. So to start off, I have a question for us to think about. Feel free to put your answer in the chat. But how many oncologists do you think practice in the US? Option 1, 20,000, option 2, 18,000, and 3, 26,000. And actually, all three of these answers are correct, depending on the source that you're looking at. Due to a decentralized healthcare system, even simple questions like this one can be difficult to answer. The solution is a new comprehensive data set of all physicians in the US, linked to their tax records and demographic information from Census, which allows us to bridge the gap between physicians and the communities they serve. This summer, I've been really interested in which communities are most at risk of physicians leaving their jobs and how that risk varies by year, physician specialty, gender, race, career age, and income, the type of attrition or leaving, so like, for example, leaving medicine versus retiring, and community characteristics like geography, with the goal of incorporating this into a composite community indicator for access to physicians. In any given year, there is a pool of physicians, but there can be new hires or inflows coming in, and then outflows leaving medicine, retiring, and dying. Defining each of these in the dataset requires estimating how long someone has been in their job or their career age, as well as when they switch jobs. Normally, this would be really difficult, but we have access to detailed data at Census on their wages, where they work, where they live over time, allowing us to infer their career age and career transitions. Once we have career age, there's a ton of really cool trends that we could look at. And everything I'm going to show is conceptual, similar to what Jade had mentioned, because the data is very sensitive. So these are just examples of things that we could look at. So for example, we could look at physician wages across career age by specialty. We could look at gender, race, and ethnicity by career age and specialty. We could look at the distribution of physicians in different cohorts or career ages across different healthcare sectors and how that's changed over time. So for example, private practice versus hospitals versus staffing agencies. Additionally, we could look at the risk of physicians leaving their jobs over time and by cohort, and how that was potentially affected by the COVID-19 pandemic. We could look at the geographic regions that physicians are moving from and to, and see if there's any trends there, especially around the pandemic. We could also look at the average years that a physician stays in their community and if there's any differences across career age. And finally, we could look at the ratio of inflows to outflows. So are physicians who are leaving being replaced at equal rates by new hires or not? And that would give us a sense of what geographic regions in the US physician access might be declining. Next steps are to combine some of these trends that I was showing with community context, for example, around differing healthcare needs, in order to quantify access to physicians for each community.
Although we aren't yet able to disclose statistical estimates yet, this process taught us a lot about the utility of administrative records and data linkage methods, and how these approaches can be applied to existing Census Bureau assets to improve our understanding of patients and providers. If there's one thing you take away from this presentation today, it should be that creatively linking with different types of administrative records can be a really effective way to unlock new insights without asking a single new survey question. We'd like to thank the Coding It Forward team for making this possible, our mentors Dean Alderucci and Anisha Santos, and of course our amazing eHealth team, including our co-fellow Sierra, who unfortunately wasn't able to be here today, and our supervisors Victoria, Aubrey, and Dennis. Thank you all so much for watching, and we'd now like to open the floor to any questions.
Hi, I had a question about ultimately the index that you may end up with something like this. Great work and really a great research question to be asking. And I'm curious if the type of index you might end up with is something that's, say, 0 to 1 and normalized, maybe to take into consideration, normalized, I guess, across the country, or if you maybe would rather end up with something that's maybe more of a raw value that isn't normalized, and just what the ideal kind of output might be for an index or something like this.
For the physician, like access to physicians.
Yes.
Yeah, so my work specifically has been more around the physicians themselves. Our co-fellow Sierra, who's was unable to present today, has actually been working on that geographic piece and visualizing, for example, physicians per capita and things like that, and has a better sense of like the different measures you might use. And then the goal is to kind of like make a more sophisticated measure that's not just, the number of physicians per capita or like per the population, but also like what are the healthcare needs? Like if there's a larger elderly population, like physicians per capita isn't necessarily the best measure. So yeah, it would be normalized in some way.
Thank you.
But
It seems like we have a question from Justin.
Yeah, I was just thinking that was a really great presentation, and I can see this becoming a really valuable product. Do you know when it might become available for researchers to use as a database?
for the physician frame as well.
Right. Well, considering like researchers looking into access to care that might not be, within the census or otherwise.
Yeah, so right now it's definitely in like the research and development phase, and hasn't undergone disclosure, but the team is hoping to get some like dashboards out soon. And then at that point, I think they would know more about, other people getting access. But the goal is to eventually have it be available to researchers and other
And
people.
just to follow up question to that, how were you able to validate the data coming from so many different states and different resources?
Yeah, so there was like a pretty strong, a lot of time spent to do that. And there will be a methodology paper coming out shortly as well with more information. But you're welcome to reach out. I'll put my email and my supervisor's email in the chat as well. But I want to make sure to have time for Christina's question.
Hi, ladies. Really good presentation. Quick question. Has your team or the Census Bureau in general thought of expanding this research in terms of nurses and maybe perhaps understanding their patterns? I know there was a lot of movement. I'm not a nurse whatsoever, but I've heard there was a lot of movement, and especially during COVID, of people leaving the profession altogether for maybe other type of related or even non-related medical occupations. I'm just wondering if like maybe perhaps your team has thought about that, or maybe perhaps the Bureau has information currently about nurses and kind of like their behaviors and stuff like that across the country.
The goal is to extend to nurse practitioners and dentists at some point.
Okay,
Which would be interesting. This is just physicians, but yeah, it's a great point.